is this whole end over here. So no imaging was done, basically because it was before me, before my time, before they knew what we could do. And this is what happens. This area was the part that was dead initially, and now the top part is involved. Okay, so now the whole territory, and this from here to here was basically a week. Okay, so it's important to open up the artery when you get the chance to. So it's important to image the arteries and open up the artery. Otherwise, this is what happens. The full territory will die, and then when it dies, it swells and it pushes over on the brain, and that's where the highest risk of immediate death from a stroke comes from. The later risks of stroke are once a person is paralyzed, they're not moving around, they get clots in their legs, pneumonia, infections in the urine, and all these sort of things just from not moving around. Yeah. Oh, is this not working? Sorry. Okay. Does that sound better? All right, I'll speak up louder then. Okay, so the important thing is, here is the original stroke. It's small. And if you don't image the arteries, if you don't open up the arteries, the risk of a small stroke becoming a full territory stroke is very high. And a full territory stroke means not being able to move around, not being able to walk, risk of infection, pneumonia, risk of clots in the legs, risk of urinary tract infection, 40% chance of death. Okay, here's another case where we did a CT perfusion. The CT scan, you don't see any findings. On the CT perfusion, it's very obvious what area is involved. Again, two little areas, kind of like on the previous study. We go in there with the angiogram, and we see that there's a small little artery here that's closed off. I go in there with a microcatheter, and boy, I wish the screens were bigger, because you can actually see that the little catheters that I use are right there, and then you can see the artery over here, and then I opened up the artery. See what's missing here, and now it's here. Okay? And the guy did great. Here's one of the most complicated cases that I've done so far. It's a 74-year-old guy who developed nausea, inability to think. His eye movements were abnormal. They were cross-eyed. He had left-sided weakness and ataxia. Ataxia is when you have like a drunk movement in your hands or legs. It literally looks like you're drunk. Same area of the brain that affects alcohol. That's why you get ataxia. We imaged him, and you can see that the artery in the basilar artery is open here, but this one's closed off on the side. Okay? It's a fairly small vessel that's closed off. We get the perfusion, and the area that's involved is the cerebellum. That's the part that makes you look like you're drunk. Then we go to MRI, and we do the MR perfusion, which I brought from Harvard to Mount Sinai, and we see that not just the cerebellum involved, but also the brainstem. You guys have heard of the medulla oblongata, the pons, the brainstem. That part is basically the pipe that carries everything from the brain to the spinal cord. So it's the most important part of the brain in terms of functioning in the body. That was involved on the perfusion scan. However, on DWI, it wasn't dead. That little white spot, that was the only thing that was dead. Okay, so we had a chance here to really do some good. Here's a comparison between the CT and the MR perfusion. It actually changed. Here the brainstem was not involved. Here it was. Okay, so between the two imaging studies, something had changed. And what was it that changed? That basilar artery that we could see on the CTA was now completely occluded. I used that Mercy device, the corkscrew. Here's the x-ray. Here's the eyes, where the eyes are. Here's the little wire coming up, and there's a little corkscrew device right there. And I pulled the clot out, and then here's the artery open with all its branches. Notice the difference. What's missing from here to here. Saved his life. This person could not breathe on his own, had to be intubated, couldn't move the left side at all. His eyes were crooked, and he wasn't thinking right. Pulled out that clot. 1 month later, he was walking again with a cane. All right, he still had a little bit of that drunken walk type of thing, but he could breathe on his own, he could walk with a cane, and he could see. So he did great. Sensational save. Here's a 46-year-old guy. Comes in. He came in at 9 in the morning. His symptoms completely resolved, back to normal. In the emergency room, he developed, again, the same symptoms at 11:25. Okay, rushed him to get the CT. The CT perfusion showed the whole area that was at risk, the whole MCA territory. Okay, the CT itself was normal. The CTA, here's the arteries, showed where the occlusion is. Okay, so there's a large vessel occluded, giving all this area risk. So there we are at the angiogram, and we can see where the cutoff is. This is closed. This is the side view. You see that these are normal arteries over here, but this area is missing. Again, normal arteries, this area is missing. I go up there with the microcatheter and I inject medication. I inject TPA, and I open up the arteries. See where it's absent here? Now it's here. What's missing here is now visible here. And I keep doing it until I get a full effect of the arteries. Make sure all the arteries are open. And that guy did great. 46-year-old had paralysis of the left face, arm, and leg. The next day he went home. Granted, it was against medical advice. He had atrial fibrillation. That's what caused it. But he didn't want to deal with the reality of having to take medications, and he left. But there you go. At the very least, he was functional again. Let me turn this off. I apologize. Next case was very similar. 45-year-old guy has left-sided weakness, inability to speak. At 3 to 4 hours, that was the best that they could tell us. The DWI did show a small stroke right there. This is the caudate. This is a part of the brain that's involved in behavioral control of motor functions. So say you want to pick something up, pick up a glass of water to drink it, he would have difficulty thinking about it, how to put his hand there. But but at the moment when I saw him, he had complete weakness of the left face, arm, and leg. Okay, so the important thing to know here is that the risk of the area involved was being affected when you saw him on physical exam. You saw weakness of the arm and leg, and the only part of the brain that was dead was the behavioral aspect of motor control. So if we didn't do anything, he would have stayed paralyzed. Okay, we went in there. Here's the angiogram. Here's the arteries. It's closed off. Put a microcatheter in there. I used a Mercy device. That didn't work. I used a medication, the TPA. That didn't work. In the end, I used an angioplasty balloon, which you can see right here. Here's his eyes. There's his nose. There it is, the angioplasty balloon. And I forcibly opened up the artery until you got blood supply back. There it is. And that guy did great. The next day, no stroke, no new stroke, right? Here's the DWI, right? That's what was dead. Okay, so no new stroke. So at that point, he wasn't weak anymore. He was having that behavioral issue where he was having difficulty deciding whether or not to grab the glass or not. But he could move. He had full strength. And that gets better fairly quickly with rehab. Here's another case. This guy's a good friend of mine after the case. I basically saved his surgical career He gave me permission to tell the story, and he is the president of the American Board of Plastic Surgery. He was giving a lecture here in Florida when he developed left face, arm, and leg weakness. And we did the CTA. There's a CT perfusion, showed all the area at risk. Okay, the CTA showed the artery was cut off there. We gave him IV-TPA. We took him to MRI. He had a tiny little bit of stroke there, very tiny. But still, there was an area here that was underperfused. And this area controls face, arm, and leg strength. So we took him to the angio suite. We find that there's a small vessel missing right there. And I put up the microcatheter in there, and there's the artery filling now. After the procedure, he woke up completely normal. The next day, we talked for a good hour or so. He said, "Alex, thank you for being aggressive. I can operate now." So that was as rewarding as it gets right there. Here's another case. This was a lovely 51-year-old lady who had a stroke, very similar symptoms. Not as much risk, not as much brain was at risk. But the neurologist was hesitating in giving her IV-TPA because she had a fracture in her leg and was worried about bleeding in the leg. Personally, if it's brain or leg, I want to save brain. But I understood where he was coming from, so I did the MRI. She already had a small stroke right there, okay? But this area was at risk. So we took her to the angio suite, and you could see how much area is actually missing, not being supplied. Okay, kind of scary to have all that die in a 51-year-old lady with 3 kids. There's my catheter inside the arteries, and there were little clots elsewhere, and I chased every one of them until I got a very nice result. And the next day, you see the CT scan, that same area that was already stroked, still stroked, but the rest of the brain was saved. 2 weeks after the procedure, that little area got better on its own. She did fantastic, perfectly normal. Here's someone, now, I got to show cases where they're not successes because sometimes it doesn't happen. Here's a case where a 78-year-old man came in. CT perfusion shows an area of risk here. The CT scan looked very good. We took him to MRI. Not just the caudate, but a huge aspect of the MCA territory was already dead. Okay? So at this point, there was nothing to do. If you open up the artery to brain that's already dead, that's just asking for bleeding. Okay? So unfortunately, we could not help this gentleman out. Here's another person that we really couldn't help out too much. We did a CTA. The arteries were all open already, but the area of brain had already died. Okay, we were talking about stenting. The latest thing is putting stents inside the arteries of the brain. There's a new stent that just came out in 2005, was the first trial, and then 2008, we started using it across the country. We did it a few times at Harvard, and now, just recently, we did it at Mount Sinai. There you can see the stent, the little ends here from here to here. It's in the basilar artery. This is the artery that supplies the brainstem, that really important part of real estate in the brain that's basically a conduit from everything in the brain to the spine to control the rest of your body. The neurologists were very nervous about this case. It's a very tight narrowing right there. And this is from atherosclerosis. The same things that are risk factors for the heart are risk factors for the brain. The high cholesterol, the high blood pressure, smoking. So there you go. And we put in that stent there, and we opened that artery up. And the guy did great. Other aspects of stroke include bleeding. There's bleeding around the brain called subarachnoid hemorrhage, and that comes from the ruptured aneurysms. Okay, we can see that here. There was a little aneurysm there. Everything that's white is blood. And then we can do the angiogram and find the aneurysm. Aneurysms and artery vein malformations, these are two entities that I treat very closely with neurosurgeons. Sometimes the old-fashioned way is to open up the skull, move brain from side to side, find the aneurysm, and put a clip there. The new advances are using coils, little platinum coils that it literally looks like the filament in a light bulb. And we can put it inside the aneurysm, and that stops blood flow inside the aneurysm and prevents the risk of rupture. Here's a compilation of, here's the artery, and there's the aneurysm. You can barely make out that there's a little tube in there that ends in the aneurysm. Here it is, putting in the first few coils, and continue putting in coils until literally it looks like a ball of yarn. At that point, blood flow stops inside the aneurysm, protecting it from rupturing. Here's a giant aneurysm. This is huge. This is about an inch. It was 2 centimeters, so maybe 3/4 of an inch. And there it is, full of coils. And you can see that the important thing is to keep the artery open at the base. And go to the ICU and take care. Here's what it looks like when an aneurysm ruptures. There's blood everywhere around the brain. Okay, and there's the little aneurysm. And here's the angiogram. There's the aneurysm. I have the microcatheter in the aneurysm. Okay, there's the aneurysm. And then with coils, you don't see the aneurysm anymore. See it here, you don't see it here. And that guy did great. One of the things that can happen in the hemorrhage, in the brain hemorrhage, is that the blood irritates the arteries and causes them to narrow, causing vasospasm. And we can treat vasospasm. We can use medication, and you see that this artery, here's the basilar artery again. Again, a very important artery. We pay attention to it all the time. It's thin, we give some medication, and it opens up. But then if we're not happy, we can actually go up there and use a little balloon. And then here it is before treatment, and here it is after angioplasty and medication. And you can tell it's a huge difference. It's very narrowed over here, and it's a pipe over here. So I'm basically a plumber, a glorified plumber. If the pipe is closed, I open it. If it's open, I close it. All right, so summary. Interventional neuroradiology is the newest subspecialty of medicine. Advances in imaging demonstrate that the brain can be saved in acute stroke. Using interventional neuroradiology techniques, we can treat strokes, we can treat aneurysms and other diseases of the artery of the brain. Also, we do treat compression fractures of the spine, being part of neuro. If you have a vertebral compression fracture, that's part of my gig too. So there you go. I hope this was helpful. Questions? All right, I think she was first. How do you prevent a stroke? The same ways you prevent a heart attack. Diet, exercise, no smoking. Gotta stop smoking. Keep going to your doctor. Make sure your blood pressure is less than 120/80. Okay? 7 years ago, the new guidelines were that 120/80, which was always considered normal, is now the high end of normal. So you don't want above 120/80. You want less than 120/80. They're both important. Yeah. So I've been there a year. Only 1 year.
I'd like to talk about a 90-year-old patient in New York who had a history of blanking out, just falling down,
stop there. In medical school, that's the chief complaint, sudden dropouts, patients passing out, right? Right there, I should have a list of what could be causing this in my head. Right now, I'm thinking seizures, and I'm thinking colloid cyst, which is incredibly rare, and I'm thinking heart problems, not enough perfusion to the brain. That's probably the most important one, but keep going.
Okay, she was in hospital overnight. The next day, she began presenting symptoms of stroke, inability to move and so on. Eventually, she developed total paralysis of her whole left side.
Uh-huh.
So I'm elderly, very elderly, maybe over 90. I asked the physician there,
Did those symptoms get better after a day?
no,
No? Okay, so she was having TIAs, then followed by stroke.
this is my question. I was told that if they attempted to give medication which would combat the symptoms and maybe return her to normal, because she was taking the blood from the kidney and other medication, she might have hemorrhaged and died in time.
That was one of the patients I showed you here. The patient on Coumadin could not get IV TPA.
Is there anything new for patients like that so that they can have the benefits of the advances without dying?
Everything that I showed you here today is the advance that could have treated her. The fact that we can go up there right next to the clot and either pull it out, suck it out, inject medication right at it, or open it up with a balloon or a stent. All those techniques can be done in the setting of a fully anticoagulated person. So, yeah. Is she okay? Did she live that? She didn't survive that, huh?
She lived less than a year after that.
Devastating disease, yeah. What do you mean by where? At the leg. That was my first image. Always going in the leg. And there's a good reason for that. When you put a needle through the skin, you can take little bits of skin with you. All right? And when you go into the artery, this is microscopic, but you go into the artery, you bring a little bit of debris from the actual bits of skin or flesh will go into the artery. If it goes south to the foot, you don't notice it. If it goes north to the brain, it causes a stroke. So the original angiogram, the very first angiogram that was done, was in the artery in the neck. And what they imaged was the stroke they caused. So there you go. Blood thinners is a very special class of medication, and it's only when you need it, okay? Now, I don't like the term blood thinner because really there's two types of blood thinners. There's anticoagulants, like Coumadin and heparin, which prevent clotting from forming. And then there's antiplatelets, aspirin and Plavix. These medications make platelets less sticky, right? Two different types. For most scenarios, aspirin and Plavix are the medications that you need. For atrial fibrillation, you need the Coumadin, okay? So if you have atrial fibrillation, I recommend Coumadin. No. A great neck massage is worth living for. It's the sudden jerking of the neck in too extreme of a direction that can cause damage to the arteries that go through the bones in the back there. So a TIA is a stroke that wants to happen, but the body produces its own TPA, dissolves the clot, and you get blood flow. And characteristically, it lasts about 15 to 20 minutes. So if you're having a TIA, and you need to go to the neurologist, and get your arteries imaged, get the Holter monitor, find out if you're having atrial fibrillation. You got to find that cause of TIAs and treat it before you have the stroke.
Can you explain the term atrial fibrillation?
Absolutely. This is a heart rhythm problem, okay? The heart has 4 chambers, 2 smaller ones called the atria and 2 larger ones called the ventricles. In atrial fibrillation, instead of getting that nice beating, pumping action, you get a fibrillating action, which is like this, okay? And so basically, you don't get a good contraction. So what happens to the blood when your atria are fibrillating? The blood along the walls stops moving, and blood that doesn't move clots. And so you have atrial fibrillation, and then from time to time, you get a good beat, and all the clots that are up on the wall get sent down and get scattered out. So that's why you need the anticoagulation, okay? Even though you're fibrillating, the blood that's pooling up here has been well thinned, anticoagulated, and it won't clot. And that's how you prevent stroke in atrial fibrillation. Yes?
Is taking the baby aspirin every day a good idea to prevent stroke?
Yes, it is a good idea to prevent stroke. In particular, if you have risk factors. Any other questions? Okay. Bell's palsy. Bell's palsy is great. This is a disease of the cranial nerve 7, okay? And it's caused, there's many possible causes, viruses, ticks, etc. There's a lot of things. But basically, paralysis of the facial nerve. And the facial nerve comes out adjacent to the ear, and it separates up to several branches. It goes to the mouth, and it goes to the face. And the difference between stroke and a Bell's palsy is that when you ask the person to smile, you get that same droop. You ask him to close his eyes. In Bell's palsy, they can't close the eye because this part is weak. In stroke, because both parts of the body, both parts of the brain go to each nerve for the upper part is always fine in stroke. So you can have them close their eyes, but the mouth is still droopy. Okay? So if it's just the droop, it's stroke. If it's the droop and your eyes open, that's the Bell's palsy. Got it? All right. Yeah. So what happened there is not really a stroke, it was a hemorrhage. Okay, she had a subdural hematoma. And what happens is that the blood collects, and at a certain point, it becomes symptomatic and the person drops. All right, they take him to the hospital. Yeah, yeah. And so when it's just a collection of blood between the brain and the wall of the skull, the treatment is make a little hole, drain it, leave a little drain there, a couple of days, take out the drain, and you're fine. No. Follow-up treatment wouldn't be necessary, just to take out the little drain. But typically that happens in the hospital, yeah. They don't. They don't. So, can low blood pressure cause stroke? If you don't get enough blood flow to the brain, you can have brain damage. So, well, now if they're walking around and doing fine, then it's not too low. Okay, guys. Thank you very much. Let's go get some chow.